So welcome everyone. This is the continuing session on success factors and barriers for scaling up malaria and other relevant digital health interventions. My name is Valentina Bu, and I am the Global Malaria and Health Partnerships Advisor for UNICEF. We're very excited that you're here, and we look forward to sharing a number of case studies with you and learning from you. A couple of housekeeping details. So please do choose your language channel for the simultaneous translation into French. It is a small globe on the bottom of your screen, and the meeting is being recorded. So please do ensure that you have registered and cleared all of the permissions. I'd like to introduce our speakers today. So we will be having a two short presentations and a short panel discussion. So today we will be hearing from Ochai Akoe, from Ali Yuba, and from Hammond Sarkawa. So we look forward to really listening and learning from them. I'd like to ask Ochai Akoe, who is the ICT4D specialist of the National Malaria Elimination Program in Nigeria, to present a country study on lessons learned from a bring your own device malaria intervention. Ochai, over to you.
Thank you so much. We are going to be talking about our successes and challenges from the digitization of seasonal malaria chemo prevention in Nigeria. This was a pilot done last year in Gombe State, northeast region of Nigeria, for the 2021 round of implementation. Next slide, please. So this is what we're going to talk about: the background, the strategy that was used, discuss the lessons learned and recommendation for scale up. All right, so the Nigerian National Malaria Elimination Program has implemented several innovations with support from the Global Fund with collaboration with state governments and partners to increase efficiency, accountability, and the overall quality of malaria interventions in Nigeria. One of such innovations is the digitization of seasonal malaria chemo prevention implementation in the country. And we already talked about the states, Gombe states, which we did pilot implementation for the 2021 round. And we also plan to scale up into 4 states this year. As we go back to Gombe State, we have Jigawa State, Kano State, and Kwara State. Next slide, please. So we had a strategy that involves the BYOD, bring your own device approach, and utilizing some digital tools with a prime focus on sustainability. We also engaged Red Rose, one of the leaders in the digital tool application development space, help us customize an SMC Android application with a data warehousing infrastructure that has the dashboard view and data aggregation features embedded in it. And we were able to roll out the pilots in the states, like we said, and it was successful, but not without its challenges and the lessons learned. A couple of slides after this, we'll discuss what we discovered. Next slide, please. So the first challenge we'll ever face, which is a usual challenge with any initial deployment of technology, is the state buy-in, acceptance of the technology. We discovered it took longer than expected for the state to actually accept the value the technology was adding to the implementation. And this, in turn, affected the implementation at the lower levels, the local government and the world levels. We also didn't know on time, and we went on to plan with an inaccurate micro-planning data, and this affected the rate of registration and also the entire coverage for the first cycle activity. Also, we discovered the capacity of the recruited personnel were yet again below the acceptable requirements, and this made us spend more in additional training, on-the-job training also. And eventually, from the third cycle and the fourth cycle, we saw an improvement. People were comfortable and confident using the technology. Next slide, please. Here are some of the lessons learned during the pilot implementation. We have realized that early engagement with the state government, traditional leaders, and other key stakeholders will help in the acceptance and the buying and the state ownership. We have this focus, which is sustainability, looking at a situation where the states can actually implement these activities on their own. And if we have these measures in place before the activity starts, it will create a soft landing for the use of technology. And early and thorough planning using verified and validated microplanning data will also help. We didn't join the team who went to the microplanning activity in the state last year, so we didn't have a picture of what was going on. We felt, well, this is correct as the activity had ended, not realizing there were, inaccuracies in the data collected. So this year we planned and we've actually implemented the microplanning with the entire states that we are going to scale up to. And this will help us envisage bottlenecks on time and also solve them even before the implementation starts. We also realized last year, because the state personnel were not given complete access to the platform, they were not fully equipped to carry out their work. And we know technology brings rich features that you can actually access and make your work more efficient or make work easier. And this year we planned they will be involved with everything we do, from the platform development to every little or nitty-gritties involved with setting up the technology for the implementation. And yes, we have all the training and capacity building initiatives all planned up for this year for the 4 states we'll be implementing. Next slide. Yes, so we will talk about the bring your own device, BYOD approach we used. Very interesting. It has its own successes and also its own challenges. One of the benefits of using the BYOD approach is the cost of procuring mobile devices and SIM cards that provide internet connectivity to these devices. Also, there will be no need to pay for insurance, logistics, and warehousing services for these devices to be procured. We didn't have to procure devices for CDDs to use for the activity, and this really drove down the cost for implementation really down. It was actually a success for us for that. Then we witnessed that compared to similar implementations where devices are provided for the community workers to do their work, you will have to set up the devices. If you are providing devices for them, you set up the devices, you provision them, and in a central place before you plan to distribute them for the activity. But here we didn't have to do that. We had them, converge at their training locations, and we did the necessary device provisioning and then set up at that level, which was easier and faster to deploy rather than gathering or assembling the devices in one place. We also realized that the community drug distributors were learning faster. Why? Because they're confident using their device and they're able to go home to practice more, and this built that confidence, and this made them more comfortable during the activity, carrying out their task during the activity. And this was a plus because at the end of the activity, first round, second round, we discovered they were like experts. They were sometimes we feel they were better than us in using a device, and this boosted the confidence of the states, and this helped also ensuring that the acceptance was on point for the deployment. All right, before I speak about the key takeaways, I will talk about some of the drawbacks we faced with the BYOD approach. The first, before the campaign even started, we drew up a personnel selection criteria shared with the state with minimum requirements needed before each community drug distributor will be recruited. Unfortunately, some parts were met, some parts were not met, and one of them became the CDD bringing their own device that was not compatible with the customized SMC application. We had a minimum requirement. It was a 2 gig RAM, and I think the CPU speed was 2.0 gigahertz or something like that. But some of them did not, some of them who brought their devices did not meet that specification. And that resulted in having the app hanging so many times, being unresponsive, and eventually crashed, and they couldn't continue the activity. This happened in the first cycle, in the second cycle, and we saw it was key to ensure that this criteria is met for future implementation. Another interesting challenge we had during the implementation was the use of VPN. There was a time last year in Nigeria where Twitter was banned, and people resorted in using VPNs to access Twitter. And I think that period became a period where people used VPNs more often than before. And we didn't see or envisage that would have been a problem, not until we started analyzing the data, especially from the first 2 days of the activity, and we saw the geo coordinates of some of these households, not in Nigeria. We saw some in Niger Republic, some in Cameroon and all that. And we had to go back to the drawing board to really know and understand what was happening. We felt the problem was from our setup, not knowing that some of these devices had VPNs installed and actively running. And when we isolated the events, we were able to pinpoint the CDDs who were affected and corrected that error or disabled the VPN in this case. We also saw that some of these devices, so-called Android devices, were having some custom installed Android OS, and this was not really compatible with the application also. We didn't realize that also. First day it worked, but second day they couldn't do anything on the device. And lastly, we saw a version, Android Go edition version of the Android OS, which is built slightly different from the default Android OS architecture. And this also affected how the app behaved. And there were some activities or some processes that they weren't able to perform using that version, Android Go. And we had to maybe get them a replacement device or totally replace the personnel if they couldn't get a replacement device. Last, I want to talk about the challenge was data security. We had a fear that there may be a data breach. We may have, we may not be able to recover or retrieve devices if the CDD decides not to do the work anymore. Yes, those were real concerns, and in 1 or 2 situations we had that occurrence happen, but we were happy to realize after we discussed with the vendor Redrose to see what type of encryption was provided. We discovered they were using the AES 256 encryption for both the Android application and the database that they provided for us. And this helped us ensure data protection and data security, since we are going to collect PI information about beneficiaries. So even if the device was stolen or it crashed for some reasons we cannot understand, we are sure that whatever information was captured on the device will not be accessible by anyone. And yes, difficulty in retrieving devices, especially in the case where the device is stolen or they have an unfortunate incident, an accident where the device fell from their hand and, broke and they couldn't access it. Yes, we had those situations, but we were able to still go back to the houses that were previously visited by that particular community drug distributor, using a new device to enter the information already recorded before for that particular beneficiary. So that's what I wanted to talk about. Then, yes, for our recommendation, we believe ensuring the technology is able to meet the intended purpose, through learning and process improvement. There was a situation where we were using printed beneficiary badges, which had a unique beneficiary ID embedded in the QR code on the badge. And we ran out of it because of the faulty microplanning data. And we had to change our process immediately. We discovered we could actually export these beneficiary IDs from the platform and share soft copies through WhatsApp to reach the CDDs faster than distributing papers to them. So we believe this was possible because we're using technology. And also, there was a place where we had children who were not captured from the microplanning, and they came with their valid reasons why they were not captured. They were on the border of two local governments. Fortunately, they couldn't be attended because each of the local governments were feeling the other local governments should be the one to service them. But we were able to use the GIS mapping from the platform to validate that they were not reached. And with that, we were able to cover them eventually before the activity ended. So these were some of the things we stumbled upon during the pilot. And we also believe with the lessons learned from the pilot implementation, we're going to scale up into 4 states this year. Thank you so much.
Thank you so much, Ochai. A really fascinating country study. I'd now like to go over to Aliou Ba, who is the Malaria Project Officer with Catholic Relief Services in the Gambia. And he will be presenting a case study comparing different tech choices and platforms and how they relate to project scale. Aliou, over to you.
Thank you very much. I would like to thank Ochai for that brilliant presentation. I will be looking at the success factors for scale, the Gambia's experience across multiple digital platforms. Next slide, please. The Gambia as a country program, we adopted technology in our malaria program in 2014. And this was as a result of a very terrific experience we had with the 2011 mass bednet distribution campaign, which was paper-based and was done simultaneously across all the regions of the country within a period of 7 days. In 2011, we had registration for 5 days, involving more than 1,000 teams, and then distribution for 2 days, making a total for 7 days. But at the end of the campaign, we really suffered to ensure that we get our correct data. So with consultations, we adopted technology in 2014, and then Catholic Relief Services bought Apple iPads, which were customized with the iPhone Builder. So when we started the use of ICT4D, we run it on a platform called iPhone Builder. The CRS supported with the training of trainers. People were identified in the country program and trained with the support of CRS, so that we also went to the regional level to do the data collectors training. We trained a total of 300 data collectors and 75 supervisors on data entry as well as troubleshooting of the devices. And then the next campaign was divided into phases, originally planned for 45 days, but lasted for almost 100 days. And in 2014, we had 97% coverage. And within a week at the end of the campaign, when all the devices were synced, we were able to get our clean data. Okay, as you can see, this is just some of the data collectors we trained in 2011 with their Apple iPads, with their solar bags and all the accessories that were needed to do the campaign. Next. Now, ICT4D in malaria work in the Gambia continued. Like when we started with the iPhone builder, CRS and the malaria continued to use the same devices in 2014 for the SMC. So we don't have to buy new devices for the SMC because we only needed to put the SMC app on the ComCare and ensure that it is working for the SMC, train data collectors on its use. And we also realized that the platform provided real-time visualization tools aligned for timely decision making, which was used to provide feedbacks for improved decision making. And then with time also, 2 years later, we moved from iPhone Builder to ComCare because iPhone Builder was deemed too cumbersome after 2 years of use because we realized that navigating the platform was posing some problems for some data collectors. And as a result of that, we were having wrong data entered into the system. So because of that, it was replaced with the ComCare, a more user-friendly for the 2017 mass early line distribution campaign, as well as we continue to use ComCare until 2021. So we also used ComCare continued to be used for SMC as well as bedded distribution at health facilities. If you go to the health facilities, the pregnant women and children under one who we service with the bed nets for routine distribution, we also capture that data using ComCare. Right. Now, this is how we transitioned from iPhone Builder to ComCare in 2017. In 2017, CRS supported the replacement of all the Apple iPads with mobile Android devices in which ComCare application was installed. 300 devices and all accessories that discharges the power banks, portable solars were procured and configured with the ITN campaign and also used for the SMC. So we use the same application. All we need to do is to change the username. One of the usernames will log you with the mass line distribution side. The other username will just log you with the SMC app, but it's the same application. So using mobile devices across multiple campaigns help to spread limited resources across several programs. Like the same mobile devices that we are using for the mass bednet distribution campaign is the same devices that we continue to use for the SMC, and is the same devices that we are using for routine distribution of early lines at the health facilities, as well as NMCP is using the same devices for the indoor residual spraying that they're using to capture data. And going forward, we plan to use the same devices for the malaria case-based surveillance. So you see, it's cost-effective. We don't have to buy any new additional devices unless we need to change old and faulty devices. But using them across multiple programs is very cost-effective and a very helpful way of using resources. The usernames and passwords were created for all the users, and a training curriculum was developed, and sessions were carried out at the regional level. So all trainings, apart from the training of supervisors, which is done at the central level, all the data collectors training is done at the regional level, where they are expected to operate. Next slide. Now, the digital experience has revolutionized data collection in the Gambia. And now, so many sectors and programs have started using ICT4D in their activities. For example, the Gambia's expanded program of immunization have started using ICT4D to register all the child's immunization, as well as on a monthly basis, the system generates SMS, which is sent to the mothers or caregivers' telephone to remind them that their children's immunization is due on a specific date. And if they don't turn up, they have what you call defaulted tracers who will go to the address or call the telephone number to remind the mother that the child's immunization is due. And this according to the EPI, has improved the immunization coverage and reduced default ratio. The NMCP now is using the digital tools in their malaria surveillance as well as case-based and IRS activities, like I have said. And when the pandemic started, CRS was able to secure some funds which they used to support homes, vulnerable homes. And we used ICT4D Comcare specifically to do household registration of beneficiaries, as well as use that information to give them cash transfers to at least support them during the difficult times of COVID-19. Now, working together, things always gets better. In 2019, CRS continued to support the training of 912 data collectors and 114 supervisors. You see now, we have started with a small group of 300. Now we are going to 912. That means the number of devices have increased. And then coverage maps were also provided, and this helps supervisors to focus and direct teams to areas not adequately served or covered. By doing all these things, CRS was able to build the capacity of partners that now our partners, NMCP, have got adequate capacity to handle the training of all the data collectors as well as supervisors, even without the involvement of CRS. I think this is a great achievement, considering that they were our co-PR, but now we have been able to transition all the services to them, and we are working with them in the malaria program as an SR. So this is a great achievement for CRS. With the NMCP, an IT and data quality team was set up to improve on data quality, solve technical issues that might have been encountered in the field. This was also one of the things we incorporated in our campaign, to have an IT as well as a data quality team. The M&E team provided daily feedbacks on coverages, as well as individual data collectors' performances, and this helped supervisors to support low-performing data collectors. As you can see from this map, this was one of our provincial towns on day one of the registration. And we always generate these maps on a daily basis, discussed with the supervisors so that they know which areas are not adequately covered. Next slide, please. So this was day 5. You see the coverage has increased. And DHIS2 is the ministry's main reporting platform. So it is very important that whatever we do at CRS aligns with the DHIS2 of the ministry. That is why in 2011, CRS provided funding for us to do a pilot for DHIS2 tracker. And this pilot outcome has been very promising. And this coming mass bednet distribution campaign we are planning is going to be done on DHIS2. And we plan to finalize arrangements with NMCP to consider whether we are going to use DHIS2 for this year's SMC and then scale it up to other regions. Now, if you look at the pilot was very, very, very successful. There was lifetime data collection using DHIS2 tracker. Data quality checks were done daily. That is, as soon as the data collectors sync their data, and the data was synchronized at the end of each day, which helped identify the areas that were not reached and whether all the children were reached compared to the previous cycle. Audit trails were available to identify data collectors who made mistakes in the data collection and to rectify them, and they were also provided mentoring. Recommendations and the way forward. DHIS2 tracker provided ease of malaria data compilation, and it is also the National Malaria Health or the Ministry of Health main reporting platform. So having everything aligned to it is very important. Any number of platforms will work, but the most important are the people and the processes developed around them will be key for success. And selection of an ICT4D platform should be done to solve specific challenges and building on national systems. The involvement of the data quality team greatly improved data quality, solve technical issues, and supported timely syncing of data, and this should be encouraged going forward. And one other thing we also found very helpful was the provision of portable routers to ensure that syncing is done on time and data is available real time. Thank you very much. for your attention.
Thank you very much, Kelly. Again, both really fascinating case studies and country presentations. Maybe we'll change around just a tiny little bit, and I might invite Hammond, who is the Senior IT Manager from the National Malaria Control Program of Ghana, to give us some brief remarks and put us into the discussion, and then we can move directly into question and answer on the case studies, as well as Hammond's remarks. So maybe Hammond, over to you for a few minutes.
Thank you very much. And thanks the earlier presenters for the wonderful presentation. I think that is very insightful. I really enjoyed it. So I will take the opportunity to touch on few factors that we usually need to consider in scaling up our malaria digital interventions. So there is a saying that it's less about technology, it's more about the people using it. So the first thing I would like to touch on is strong leadership. And I would like to quote what John Maxwell said, that everything rises and falls on leadership. So the first success factor that I considered and what really helped the Ghana story in scaling up from just 4 districts to 201 districts in less than 6 months, the first thing is about strong leadership. So the leadership sets the tone for the whole exercise. How? The leaders are well convinced of the way forward. They buy into the idea that there is a need for us to use technology in our malaria interventions, and also there is a need for us to scale up to the other regions or districts or the communities. The leader clearly articulates the way forward, and also the leader finally makes resources available on time. So the Ghana story reintroduced a system that we call NetApp, the mobile application of which we did a pilot only in 4 districts out of 209 districts. That is, in 2010 year, we were able to distribute over 10 million of nets in 3 years. But after introducing the technology, digitizing this intervention PMD, and also scaling it up, we were able to move from 4 districts to 201 districts, and we were able to distribute over 15 million of nets in less than 10 months. So the first factor that I will consider is leadership. The second factor that I will speak to, it is also the IT governance. So what is this IT governance all about? The IT governance says that the possible structures that we need to put in place in order to achieve the successes that we are looking for. It's a new direction, that it must come with a new ways of doing things. So what the Ghana story did was that we saw that as we are scaling up from smaller communities or districts to the higher platform, there is a need for us to get some policies in place. We are moving and collecting persons' data or beneficiaries' data. So we taught as much that getting the data protection certificate, which allows us to collect data and also processes data. We are now using mobile handheld devices. And so we moved from a list of 200 mobile handheld devices to over 5,000 handheld devices. It called for the need for mobile handheld device policy. Now we look at the data that we are collecting. It's a data that is going to move in motion, but the data will not be at rest. It called for an IT security policy. And also there is a need for us to segment the work because now it is becoming big. The need for us to know who is doing what. When we are able to put in all these policies and when we are able to go about this IT governance very well, then it puts confidence in the beneficiary and it gives us also the assurance of the privacy, the confidentiality, the integrity of the beneficiary data, which is fully protected. Looking at the governance also, then it brings in mind that what are we looking at? Which of the platform will be more advisable? So we chose the Android version. So after choosing that Android version, then we narrow down the discussion, are we doing bespoke software or we should look at in-house building? we looked at the in-house building. Why? Because we had the sustainability, our ability to easily scale up, and the customization of the product. So all our digital intervention tools are something that we developed in-house. And developing in-house brought us so much of advantage that we can easily tweak it and we can easily go about it in other ways to get our information and data on time. The third factor that I would like to touch on, it is what are the advantages that the digital tool we have invented or the digital tool that we have brought in place, what other benefits are other programs and other interventions also receiving from. So looking at the data, we started with the PMD, that is the IT and distribution, using a mobile application called Data. It helps us to be able to pick the data and the geospatial data. So at the close of the data wasn't helping only malaria interventions or malaria cases. It also provided data for the health sector in terms of the coordinates that we use for other research. Also, looking at this data, we are planning that one thing that we have seen is that the beneficiaries or the hospitals and the districts were putting their data together manually, but digitizing this tool helped with a click of a button be able to get all their reports at the click of a button ready for them to translate that into the DHIS2. Currently, plans is far way advanced that we started less than about 2 weeks ago. We are looking at how best we can now automate, or how best we can, there will be an interoperability between the digital tools that we are having into the DHIS2, so that at the click of buttons, all these reports move seamlessly into the DHIS2 platform without any manual intervention. So the system that we automated, the malaria tools that we digitized, it is not only helping the malaria intervention, but it's also helping other programs where they are able to get quality data for quality decision making. So to sum it up, I'll just focus on 3 things that I've spoken about: strong leadership, I'll talk about strong IT governance. The third thing is that whatever tool we are intervention should also bring added advantage to other programs and other intervention. Thank you for now.
Thanks so much, and that was really fascinating and a great summary. I'd like to invite our three panelists and speakers to please come on video, and we're now going to go into the Q&A and discussion portion of this workshop. So one of the first questions that has come through is for Ochai, and they had a question on how did you select your LGAs for the pilots, and also how did you ensure secure data privacy? Ochai, over to you.
All right, thank you so much for that question. So the pilots happened in Gombe State. We actually plan to have the pilot in 2 states in Nigeria, Gombe State and Kano State. Kano State has 44 LGAs, local government areas. Gombe State has 11 LGAs. And looking at the term pilot is something you need to do or implement in a small scale, not in large scale. And selecting between the Kano State and Gombe State, we discovered Gombe State would be a best choice for implementing a pilot. And the implementation was across the 11 local governments in Gombe State. That's how Gombe was selected for the pilot. Therefore, data protection, the services that Red Rose provide for us, we have the access control feature on the database. We have the administrative privileges given to different users on the database. This ensures that there's no unauthorized access to privileged information unless it's required or necessary for you to have that. Then we also daily monitor the users on the platform to ensure consistency all through the period of the implementation. So these were the few measures we put in place. Thank you.
Thanks so much. The next question is for Hammond. And the question reads thus: for in-house building of applications, what did that mean for your National Malaria Control Program staff? It is recognized that developing apps and tools in-house requires specific expertise that is often contracted out. Were staff with specific information and communication technology expertise hired by the NMCP and their positions sustained indefinitely for long-term troubleshooting? And what did it take to commit to funding the staff to manage these tools and applications? Hammond, over to you.
Thank you very much. So with the National Malaria Control Program, we have I'm an IT person engaged by the program, and the program also engaged an additional IT person. So with the with the skill set that we had, we also brought other people from board within the same health sector, where we were able to develop the system from scratch to the final of it. When it comes to providing support for it, we make sure that we train all our regional IT managers, and also we train the district health information officers. Going live scale, we thought that it will be very difficult for us to troubleshoot the system from only the NMCP head office. So we build the skill set around all the regional and the district HIs, so that they'll be able to troubleshoot anytime the need arises. So as part of our training exercise, we were doing something we call the IT bootcamp. So in the IT bootcamp, we make sure that we impart every single person that needs to handle this application at every point in time, so that there wouldn't be pressure on the IT officers at the national headquarters. Also, we realized that there is a need for us to create a platform for the technical group and also for the managers group. And so on the technical platform, anytime there are challenges, they post it on that technical platform. And in less than 2 minutes, answers are being provided when the questions are asked clearly. So I can sum it up that we had a skill set in-house. We engaged 2 IT professionals, myself and my junior staff, and we also brought in other IT personnel within the health sector together. We introduced the IT bootcamp, which we train all manner of people how to troubleshoot, and we also created the platform of which people can report incidents for quicker answer. Thank you.
Thank you, Ahmed. The next question is actually for Aliyu. And could you delve a little bit more into the challenges of switching digital technologies 3 times? As we heard from Hammond, sometimes you have to build quite a lot of in-house capacity. How did the Gambia address these complications and these challenges? Aliyu, over to you.
Yes, thank you very much. One of the challenges we had is that our IT department has only 1 staff. And like what Hammond have said, we have to engage the other IT staff from the Ministry of Health, because our key partner in the malaria program is the National Malaria Control Program. So we have to also engage their IT personnel and the people who were first trained during the TOT to ensure that when the devices come, they are all configured on time, they are all charged, they are all tested to ensure that everything works fine before they are deployed. So they have to also ensure that the inventory is taken. So the key challenge there is the IT, the availability of adequate staff. But apart from that, the other collaboration from the other sectors ensure that we move from a small scale. Now we need almost up to very close to 500 devices. So as we are going close to the campaign now, all our devices have been set. They have been fitted with the app that we're going to use for the campaign. Usernames have been created and tested. So collaboration is key in everything to avoid challenges. But that doesn't remove the challenge of the 1-man IT staff at CRS. The content program, we have only 1 staff there.
Thank you, Aliyu. The next question is for Ochai. You mentioned that the bring your own device approach is a better choice because it is not only cost effective, but it also builds confidence faster in field workers. However, how do you address the challenge of populations that are illiterate and those who may not be able to read or write? Ochei, over to you.
Thank you for that. So before the pilot implementation was done, there was a form of survey that was done in 3 states in the northern Nigeria where it is perceived low literacy was predominant. And out of the result that came out of the survey showed that 98% of the locals actually own an Android device. And that helped us build the confidence around moving with the BYOD approach. Yes, even with the implementation and previous implementations in the case of the ITN mass campaign activities, we've seen people who have the capacity to use modern technology at that local levels to carry out their daily activity, even with similar health interventions that are being done in their localities. So these were the things we, formed and helped us build that confidence that we could go forward with the BYOD approach in Nigeria. Thank you.
Thanks so much, Ochei. So the next question is for Hammond. You mentioned that there is a switch over when we're going from paper-based to digital-based. You have a large staff, so how is it that we can build in the time for training and building up capacity when we are moving from paper-based systems to ICT4D deployment? Hammond, over to you.
Thank you very much. So with my experience on moving from paper-based to the electronic, I believe that it calls for a lot of change management. And the change management training, very key. And as I rightly said, that the leadership factor is also key. I've come to realize that when the leadership sets the tone with clear-cut direction, everybody falls in line and falls in place with it. And the resources are being made available for all the other possible things to follow. So what we came out with is that there is a need for us to do the training, but what training? It should be more of visuals. So all our training slides were so visuals, and also we introduced a technology for all the automated system was also in a video form. It was a short video, maximum of 1.5 minutes, of which we handed it over to the volunteers or the data collectors on their tablet. So if you are lost of any process, just have a time and watch the video. It teaches you what to do. And so picking our data for the first time wasn't much of a challenge for us because we did a cascading training. We trained the regional officers, and the regional officers also built a lot of capacity that were able to train the district officers. The district officers built a lot of capacity. They trained the sub-district officers. And the training was so simple because they were all videos illustrating what needs to be done. And so I strongly believe that when we are able to gather the resources, we make the resources available on the tablets of the volunteers. The volunteers can easily watch it anytime they are lost of a section or a track. Then they can easily get it done. So we believe in the policy where every device that was handed over to the volunteer or to the data collector has every information needed for the exercise on the tablet in the form of a soft copy and also in the form of a video to direct them anytime they are lost out of the process. Thank you.
Super, thanks so much, Hammond. Aliyu, a question to you. Given your experience on scaling different platforms, what lessons learned and recommendations would you have for other countries?
Thank you for that question. I think one of the lessons that we have learned is to always work on time. The first, you have to look at the market and ensure that the type of devices you need the specification can be procured locally. And once you've got those things, you have to ensure that you place your procurement early. Because, for example, Gambia, we only usually use a small quantity of devices. The maximum what we have ever used is 456. So, and these are available in the country. We have shops that can supply the quantities and very qualitative devices locally. So availability locally should also be factored out, because if it cannot be available locally, where you have to buy it out of your country, you have to look at the delivery time and all those things. So that's very important for you to factor in. The other thing also is to have the required IT personnel to be able to ensure that once the devices are received, they are charged, they are tested, they are configured, and they are inventorized. Once all those things are done, because operation is done at regional level, they are also packed by district to ensure that the supervisors will just come collect them. So all those things need to be done in a manner to avoid delays. I think those points are very, very, very essential.
Yeah. Super, thanks so much. Ochai, I'm going to give you the last question and also give you the 1 minute for closing remarks to sum up the Nigeria experience. So the question is, we do know that for most campaigns and whenever we're doing calculations, it's difficult to get the population data. So which did you use? And do you have a sense of which populations were missed? And what do we need to do to cover those populations? So if you could answer the question and then a 1 minute summation of this from our presentations today.
Sorry, I was speaking on mute. All right, thank you so much for the question. I want to also say, I mentioned during the presentation that we realized late we used the faulty microplanning data for to plan for our implementation, and that was a situation we had to manage in the first cycle implementation. So we have a round is made of 4 cycles. And we work in the States, have a break of 2-3 weeks, go back to the state again, and for the 4 cycles. And when we realized we were working with the wrong microplanning data in the first cycle, we actually saw that effect when registration was ongoing. We printed beneficiary badges with a QR code and beneficiary IDs embedded in the QR code. And that was what was used to register the beneficiaries. So CDDs were running out of the beneficiary IDs, and we didn't know why. We felt the quantification was correct, whereas we now stumbled on the fact that it was the wrong quantification. So we changed the process improvement. Now we changed our process. Rather than having the badges printed on paper, we moved to the digital format, and we were able to share that with the teams through WhatsApp, and it got to them faster than the printed paper would get to them. That was one we did. And in the second cycle, we were able to update our denominator, which is the foundational data for the population. And that also helped us see the areas that were missed from the first cycle. And we're able to use the GIS feature of the platform to actually validate the areas that were missed, and we're able to adequately cover them from the first and second cycle up to the last cycle. So those are the things we did, and we also realized planning this year, we need to have the grassroots level data to plan and develop our strategies around. And this will help us ensure no eligible child is missed for the year. Right. So
great summation. Thanks so much, Ochai. We're going to move on to Hamid. So Hamid, one second summation.
Thank you very much. So I can sum it up that digitizing malaria tool intervention is the way forward. And also, it is very expensive initially. but the long-term benefit is something that you can really enjoy. The future, you get your quality data, you have quality data for decision making, you'll be able to make real-time decision, and it's something that will provide other solutions for other interventions. Thank you.
Thanks so much. Aliyu, 1 minute summation.
Yes, I completely agree with what Haman have just said. I think digitalizing our activities is the way forward. And in the Gambia, we will continue to support our partners to ensure that all our data is digitalized for efficient and timely decision making. Thank you.
Thank you so much, colleagues. So let me give you a few very brief closing remarks, summarizing everything that we've heard today. So what's really vital is, as was mentioned multiple times, leadership. Leadership is very, very key. So ensuring that we've engaged our leaders, ensure that they see the value and the cost effectiveness of the digital platforms that we are proposing is vital. It's also vital to ensure that we are doing capacity building, not only at central level, but also all the way down to decentralized level. It's also important that we take into consideration the varying levels that are throughout all of our populations and those that we mean to serve. It's important to use visual platforms, which will also help with language differences, that we ensure that we are building in opportunities to refer back to lessons learned, which will also help, again, improve capacity and ensure adherence and implementation. Change management and training are also vital, and we need to build that into our budgets as we scale up and we roll out. Planning and early planning and procurement and forecasting is also vital to ensure that we have the right commodities, the right training, and the right management in place, and that we can include these into our budgets and into the opportunities for rollout and scale out. Adaptability and use of various platforms is vital. Each platform will ensure that we have lessons learned and that we can continue to capitalize and roll out and build out. We cannot forget that we have to have grassroots and community level engagement so that we get the right feedback and that we have good feedback loops on the opportunities and platforms that we are rolling out. And the key lessons learned is digital platforms are initially expensive, but they are vital for our future. Our future populations, our children are counting on us to make the right investments and to ensure that we are building out, getting the data, and improving at every step of the way. With that, I'd like to really thank you for your participation. I'd encourage you to please fill out the poll. We look forward to your continued engagement, and we hope you enjoy the rest of the conference. Thank you very much.